like to request you, Dr. Vivek Gupta, sir, please start your presentation. Over to you, sir.
Okay, thank you very much, the team of Waringal. I'm always glad to participate in your programs, and your programs have been very interesting and also great learning for overall physicians and doctors. So I'm going to share the slide now, and can you see the slides?
Yes, sir.
No, just a minute. Can you see the slides?
Yes, sir. Yes, sir. Your slide is visible, sir.
Okay, so today what we are going to talk about. You see, diabetes mellitus has been a big challenge, especially for Asian countries, and especially because India is a huge population with almost 130 or 140 crore of population, 1.3 to 1.4 billion, and out of which diabetes is known to be a world capital, and especially 2025, it will be world capital. So we have been always challenging to treat the patients and to have a good outcome, and it should be safe as far as overall safety is concerned. So today what we are going to talk about is diabetes mellitus. Simplicity according to the specific topic will be that what are the anti-diabetic medicines which are more safe as compared to others when you're controlling, bringing down to HbA1c, especially cardiac wise and renal wise. That means they should be safe in the patients who are already having cardiac disease, and also those patients who have got end stage or almost nearing end stage kidney disease. So coming to starting, I would like to start the presentation with some data and as well as how the diabetes is formed. So thin fat Indian phenotype and high cardiometabolic risk. The common soil in Indian population, an essential interplay of many items. First of all, there is the unhealthy lifestyle habits, and there is environmental predisposition, and of course there is some in utero nutritional programming. This is very new term, and people should understand that. That means this shows that there is a genetic predisposition to have insulin resistance, leading to high blood sugar levels and leading to end stage organ damage, and leading to, of course, disturbed profile overall. And this all lead to insulin resistance and cardiometabolic risk. So genetic factors plus maternal chronic malnutrition. It's very important that there are a lot of patients who are malnutrition during the time of pregnancy. This leads to intrauterine growth retardation, and this is a typical Indian neonatal phenotype, which having reduced protein-rich organs, that means reduction in proteins in liver and muscle, and of course increased adipocytes, increase in energy intake, decreased energy consumption, and of course infectious environment. All this lead to central adiposity and macrophage activation, leading to endothelial dysfunction and insulin resistance. And this patient who is genetically predisposed because of so many factors, he is likely to become a patient of coronary artery disease, which is angina and heart attack, and of course also diabetes mellitus. And these two are sometimes interlinked to each other, but the common pathway which leads to all these things is basically starting at the time when the child is still in the uterus. And this is important of in utero nutritional programming. If you enrich the diet of the pregnant lady, this patient will not become CAD. It's a very interesting item, and I think we should understand. That is why chronic malnutrition in pregnant ladies can also give rise to child who is likely to become a CAD and diabetes mellitus patient. That's why we have seen the data that patients who are even in the lowest socioeconomic patients have a high preponderance of becoming diabetic, as well as CAD patients, angina and heart attack. So overall prevalence of CV disease in patients with type 2 diabetes, known CV disease, 1 in 3 patients with diabetes have chronic CV disease. Very interesting. 30% patients of diabetes will have a chronic cardiovascular disease. Subclinical cardiovascular disease, 2 in 3 asymptomatic patients with type 2 diabetes mellitus have subclinical CV disease. That means diabetes control is very, very important, because if you have such a high incidence of diabetes, of incidence of CV disease, subclinical or clinical, then of course you have to treat diabetes very well. So CAD 1 in 5 patients, known diabetes CV patients, if you see that 1 in 5 patients will be diabetic, heart failure 1 in 7, and MI will be 1 in 10 patients. So this is the data coming from various journals which is published in 2018, 2007, 2014, and therefore this is important to understand diabetes and more so to treat the patients. Potential effects of COVID-19 pandemic on cardiovascular disease outcomes. This is very important slide because we have been suffering for almost now 2 years or 1.5 years with diabetes mellitus and COVID patients. Last year it was almost washed out time when we did not have any physical meetings. But we should understand that this virus is so dangerous that this has got also impact on the overall cardiovascular disease outcome. So this is not this virus COVID-19, which is coronavirus disease, is not only disturbing the lung, leading to of course high HRCT score, and of course also leading to pneumonia and death. Especially wave 2 was very seriously, patient got infected and the patient died within 1 week also. But not only that, it has a bad cardiovascular disease outcome that I have seen myself, that I have patients who were admitted under me as a COVID. We did the angiogram and we found that there was the accelerated atherosclerosis and possibly the left main disease, and patient was having bypass surgery was required in such patients. So this is the timeline we resolved. Primary impact that it can lead to acute CV event, and secondary impact is deferred or delayed CV management due to healthcare restriction and infections. And tertiary impact is influence of pandemic-related social and economic factors. So all these three, the primary is of course when the patient can have an acute coronary event, that means acute MI or unstable angina. Secondary impact, but because now the whole hospital is converted into a COVID hospital, and therefore there is a limited beds available for treatment of primary angioplasty or otherwise. And tertiary impact is because of the social and economic factors. But this virus is dangerous, and of course it has got not only this, but COVID cardiovascular complications are known, leading to myocarditis, tachycardia, palpitations, pericardial effusion, myopericarditis are rare, but most common cardiac involvement is myocarditis in patients of COVID. And I have seen young patients still coming to me on video consultation that they have palpitations, their heart rate is about 120 and the 30, young 25-year-old, 28-year-old. And when we do cardiac MRI, this is positive, but many times we are not able to do such high sensitivity test. And we of course give medicines which can control the heart rate, and patient becomes all right. Of course, we have to do echocardiography, and also we have to do chest troponin to find out and diagnose myocarditis. If it is severe, it can lead to cardiomyopathy. If it is mild, patient will recover over a period of few weeks' time. So this is another complication. Considering the potential metabolically interfering effects of drugs in suspected COVID-19 positive patients with type 2 diabetes mellitus, we have to understand that potential metabolically interfering effects of drugs in suspected or COVID-19 positive patients. So we have found that metformin, the consideration is that dehydration and lactic associated patients are dehydrated, so patient will stop taking the drug and follow 6-day rules. During illness, renal function should be carefully monitored, because if the patient is on metformin and the patient is also COVID positive, then you have to take these considerations, and especially the renal function should be carefully monitored because of high risk of chronic kidney disease or acute kidney injury. If your patient is on DPP-4 inhibitors, are generally well tolerated and can be continued. In COVID, we are talking of COVID patients. So in COVID patients, you have to have some guidelines that metformin, you have to be careful with DPP-4 inhibitors, generally well tolerated. SGLT2 inhibitors, there is a risk of dehydration and diabetic ketoacidosis, and therefore we have to be careful. Patients should avoid initiating therapy during respiratory illness. Renal function should be carefully monitored. GLP-1 analog, dehydration is likely. Insulin therapy should not be stopped. Regular cell monitoring blood glucose every 2 to 4 should be encouraged. So the out of so many all the medicines, DPP-4 inhibitors and insulin are best advised in the patients who are moderately sick in COVID-19 pneumonia. This is general rules. So other things should be avoided. You should depend upon insulin or DPP-4 inhibitors. So this is the Government of India guideline to initiate OAD in patients newly detected to have diabetes or admission and this is the screening of hyperglycemia in every patient hospitalized with COVID-19. You have to see for screening of hyperglycemia in every patient hospitalized, and this has been a big problem, especially in wave 2, that the patients were treated with steroids, and the steroids precipitate diabetes, and a lot of patients have had blood sugars level to the extent of approximately 300, 400, 500, and they disturb the whole metabolism, and therefore this was a big challenge. And of course, we all know that black fungus was also precipitated. These patients who had a bad high blood sugar and steroids were the victim by black fungus, and many patients died because of many black fungus alone. So if there was no steroids, no hyperglycemia, and then if there was good control of blood sugars in patients of COVID with severe pneumonia, black fungus would not have actually taken the toll. DPP, coming to the DPP4 management, I'm just leaving the COVID-19 now, and we have to now come back to DPP4 inhibitors and type 2 diabetes management. What are the key principles in type 2 diabetes mellitus according to AAC 2020? You have to do a lifestyle modification underlies all therapies: weight control, physical activity, sleep. You have to avoid if your patient is on diabetic medicines, anti-diabetic medicines, you have to avoid hypoglycemia. It should not cause weight gain. It should individualize all glycemic target. That means patient AIC should be well controlled, and fasting blood sugar and PP blood sugar should be well controlled. This should be, of course, this is individualization. Optimal AIC is about 6.5 or as close to normal as is safe and achievable. Therapy choices are potent, patient-centric, based on AIC at presentation and shared decision making. Choice of therapy, of course, also reflects the acute events of heart disease, CHF, and renal status. Comorbidity must be managed with comprehensive care. Get to goal as soon as possible, adjust at 3 months until at goal. Choice of therapy includes ease of use and affordability, and of course we have to see CGM is highly recommended as available as assist patient in reflecting goal therapy. So DPP4 inhibitors, we have a lot of advantages. If you see the overall requirement in diabetes mellitus, as you see on the left side, and now we see DPP4 inhibitors, it has a low risk of hypoglycemia. It is weight neutral, does not cause obesity. It is cardiovascular safe. Safety profile similar to placebo is very important. Few interactions are there with co-medications. No timing or dosing issues with linagliptin, especially with linagliptin, and a good compliance with the patients. So comparing with, you see we have 5 types of teneligliptin, vildagliptin, linagliptin, sitagliptin, saxagliptin. So, but all these gliptins have a low risk of hypoglycemia, weight neutral, does not cause obesity, safe cardiovascular wise, safety profile similar to placebo, only few interactions with co-medications. With linagliptin, there is no timing or dosing issues, and the good compliance. So now the question arises that are all DPP4 inhibitors equal? That means Saxa, Sita, Lina, Vilda, and Teni. So what does the evidence say? The next slide will be that now we'll talk mostly with the linagliptin in perspective. So pillars of simplicity with linagliptin. It's proven HbA1c lowering efficacy. Now we are comparing all the gliptins. The next slide will be basically on linagliptins and its perspective and the utility and safety and overall effect. So what is simple in linagliptin? It is proven HbA1c lowering efficacy. It is demonstrated cardiovascular and heart failure, renal, hepatic safety. Convenience of one dose, 5 mg once a day without a need for adjustment. This is very important. And of course, it has got a rich positive experience across diverse patient groups in clinical practice. So linagliptin is having superiority as far as safety and convenience of dose, hepatic safe, CV safe, heart failure and renal safe. So we'll touch upon all these 4 points one by one. I'll just show you that we'll touch upon the efficacy, then we'll talk about CV evidence, then we'll touch upon the renal evidence with Lina, and then we'll touch upon convenience and adherence, and all these with the data, and then of course we'll touch upon the experience of broad range of patients. And this is how we will finalize this slide presentation. So coming on to the first portion, which is efficacy. So let us talk about the efficacy of linagliptin. Glucose lowering efficacy with DP4 inhibitors in general, all the gliptins have comparable efficacy. Significant AIC reduction with linagliptin, significant AIC reduction with metformin in type 2 diabetes with high baseline. This is a general analysis, and meta-analysis has shown of 83 random clinical trials comparing the efficacy of DP4 inhibitors in patients with type 2 diabetes, no head-to-head trial comparison. Meta-analysis of 83 RCTs comparing the efficacy of DP4 in patients with diabetes mellitus. This is Sita, Lina, Vilda, Sexa. And if you compare that significant reduction in HbA1c with linagliptin as well as other, but if you compare with monotherapy with metformin, this is significantly better as far as gliptins are concerned. Hypoglycemia remains a clinical challenge. Sulfonylureas as second-line drugs are associated with increased risk of severe hypoglycemia. We all know that sulfonylurea, which has been very commonly used salt for control of diabetes mellitus, is having a small problem that it can sometimes lead to hypoglycemia, which can be really dangerous because it can lead to acute MI, especially when the patient is sleeping. It can lead to silent MI, silent death. So we have to be very, very careful, and we have to tell all the patients who are on sulfonylurea that if they have loose motions, if they're not eating well, if the appetite is reduced for some reasons, then these patients have to stop that medicine. But this problem is not there with gliptins. So long-term glycemic efficacy with linagliptin is similar to sulfonylureas, 2 years. Because why we need to compare this? Because sulfonylureas are very well established anti-diabetic agents for almost many decades. So we have to now with the salt, which does not cause hypoglycemia, which is DPP4 inhibitors, we have to compare the efficacy with the already established anti-diabetic agent. And we have found that long-term glycemic efficacy with linagliptin is similar to sulfonylureas, 2 years data, 7% lower risk of hypoglycemia with lina versus glimpride. And this is a very important sentence. 77% with lower risk of hypoglycemia with linagliptin, which is DPP4 inhibitors, and glycemic efficacy of linagliptin compared to glimpride and lower risk of hypoglycemia. So now you have a salt which does not cause hypoglycemia. It is as good as sulfonylurea. So we'll of course choose this unless there is some other reason to not to use it. An important trial, Carolina trial, which was published in ADA 2020, and it has shown that linagliptin resulted in significantly lower first and total events of hypoglycemia compared to glimpride. This Carolina also compared that there was a much less risk of hypoglycemia as compared to sulfonylurea, which is glimpride. Body weight is an important patient-centric consideration type 2. ADA recommendation: when choosing glucose-lowering medication for overweight or obese patients with type 2 diabetes, consider their effect on weight. Whenever possible, minimize the medication that cause weight gain. 1.5 kilogram relative weight loss with linagliptin versus glimpride. So it does not cause weight gain, but in fact it has been seen that over a period of almost 240 weeks, this is 16 weeks, 32 weeks, 48 weeks, they have found that there is a 1.5 kg relative weight loss with linagliptin, and therefore it should be the drug of choice, especially in overweight patients. Hypoglycemia and weight reduction, important consideration in elderly, especially elderly. A lot of patients are having overweight or obese, and of course the detection of hypoglycemia in elderly population can be little retarded, and therefore this is a very important consideration, especially in elderly. And 83% relative risk reduction in hypoglycemia with modest weight gain with linagliptin. So elderly patients more vulnerable to complication of hypoglycemia because I told you that the diagnosis of hypoglycemia may be little slow in elderly patients. Impairment of autoregulatory response, the symptoms of hypoglycemia are often much less specific. For example, the symptoms of hypoglycemia are less specific in elderly patients because of impairment of autoregulatory response, and they're more prone to effects of hypoglycemia, including hospitalization, mortality, long-term impairment of cognition, altered sensorium, effect on the cerebrum, and leading to serious problems. So therefore, we can't afford to have hypoglycemia, especially in elderly patients. With linagliptin, less patients initiated or increase insulin dosage. This was Carolina trial. Time to initiation of long-term use of insulin, long-term dose of insulin. That means the patients who were with linagliptins, less patients required, or they were required at a later stage. That means insulin requirement was delayed when the patient was on linagliptin. Coming on to the cardiovascular safety evidence, CV evidence with linagliptin, you see the Carmilla trial as well as Carolina trial, linagliptin has been statistically evaluated for both CV and kidney outcomes. And Carmilla trial, if you see linagliptin and 3980, if you see the primary endpoint of MACE, major adverse cardiovascular event, and secondary endpoint of composite renal point, there was much reduction in the MACE as well as composite renal endpoint when the patient was on linagliptin in both the trials. So broad patient profile study with Carmelina and Carolina, if you see that this is the data, diabetes is a progressive disease, initiation and progression of complication, high renal risk, albuminuria, proteinuria, declining EGFR leading to ESRD and CHF, and high CV risk. This is a very important, good slide, well made slides, and therefore this leads to, diabetes can lead to progression of complication of left ventricular hypertrophy, ASCVD, and of course renal complication leading to end-stage renal disease as well as congestive heart failure. So CV and renal complication outcome with DPP-4 inhibitors, linagliptin is safe across all CV and renal outcomes. This is of course the comparison of studies should be interpreted with caution due to the difference in study design, population methodology, and this is SAVOR TIMI 3 trial with saxagliptin, and of course Carmelina trial was linagliptin, and CV and renal outcomes with DPP-4 inhibitors. Linagliptin is safe across all CV and renal outcomes. The standards of ICH-E14 to assess pro-arrhythmic potential evidence with various DPP-4 inhibitors agents. Assess for QTC as per as ICH results. Linagliptin, if you see that this does not, we're talking about pro-arrhythmic potential evidence coming from various DPP-4 agents. Linagliptin, and we how do we check it? We check with the QT interval, which is QTC interval on ECG. As per the ICH-E14 lies, it was seen that there was no QT interval prolongation with linagliptin, and therefore it becomes safe as far as arrhythmia is concerned. No clinically meaningful QTC prolongation with sitagliptin. Oral QTC prolongation not seen except 100 milligram OD dose at 1 and 8 hours. So there was some question mark. And teneligliptin QTC prolongation is a known and label risk. So if you see the patients who have got high risk for arrhythmias means the patient who had somewhere acute MI, or the patient has got some scar, or patient who has got on Holter monitoring, some sort of arrhythmias or ventricular ectopics are noticed. Then if you see that it is safer to use linagliptin as compared to Vilda or teneligliptin, because these two salts, especially teneligliptin, has been known to cause arrhythmias, and QTC prolongation can be a serious problem because this can lead to multimorphic ventricular tachycardia and sometimes ventricular fibrillation. So we have to be very, very careful in the patients who have got an acute history of any acute MI or history of low ejection fraction, especially ejection fraction less than 35. These patients, if they are on teneligliptin, they have a high risk of QTC prolongation, which can be dangerous because these patients can have acute cardiac arrest. And therefore, it is safe to be using the safer compound, which are linagliptin and sitagliptin. Of course, of these two, lina is the safest. So the patients who have got a high potential of arrhythmias, and these are the patients who have congestive heart failure or ejection fraction less than 35%, patients of chronic or acute CAD, these have to be very careful, and therefore lina becomes at the top as far as indication. Lina can be used safely. Subgroup analysis from Carmelina, linagliptin showed a nominal reduction in HHF in certain hospitalization because of heart failure in certain subgroups. So North American, Asian, and patient not using insulin at baseline, the subgroup analysis showed that there was a reduction of 35% relative risk reduction, 3% relative risk reduction, and 38% relative risk reduction when the patients were on linagliptin, and if you were reduction in hospitalization because of heart failure in certain subgroups. That means it is safe. And there's a reduction in hospitalization. That means it is so cardioprotective that the hospitalization because of heart failure is also reduced in certain subgroups. There's no increased risk of hospitalization because heart failure was consistent across high risk group. The Carmelina trial showed that linagliptin did not increase hospitalization because of heart failure, regardless of baseline characteristics such as history of heart failure, renal impairment, and insulin usage, word, region, age. Of all these six, despite the patients who have got a high risk of hospitalization because of heart failure, at least linagliptin did not show any further increase. In fact, in these three subgroups, it shows the relative risk reduction. But in general, it did not increase the heart failure hospitalization across all these groups of heart failure, history of heart failure, renal impairment, acute events, insulin usage, word region, and age more than 65 years. What are the ESC ESSD guideline 2019 DP4 in patients with type 2 diabetes with heart failure? When we are talking about heart failure patients and recommendation in heart failure patients, now we are talking of patients heart failure. I just want to tell the audience what is heart failure. Heart failure does not mean that heart has failed. It is a specific condition where the heart functioning, systolic heart failure is a heart failure where you have a reduced ejection fraction less than 35 or 40%, normally 60%, and there is another which is a preserved ejection fraction heart failure. Here there is diastolic dysfunction, left ventricular hypertrophy, and the heart is not able to relax completely, and this can lead to hospitalization, requirement of hospitalization, and the patient become breathless, and the patient is in pulmonary edema in both the conditions. So this is heart failure. So what are the guidelines for DP4 in patients with type 2 diabetes mellitus with heart failure? The DP4 inhibitor CETA and linagliptin have a neutral effect on the risk of heart failure hospitalization and may be considered for diabetes mellitus patient with heart failure. That means it's class 2B or class 2B agent. Success significantly increased the heart failure. Why are we talking? Because now we are comparing the three. We are comparing Lina, CETA, Vilda, and Teni. Now we have compared in pro-rhythmic. Now we are comparing with the heart failure patients. So in Lina and CETA, it is safer and they are not increasing the hospitalization because of heart failure. While Sexa and Vilda, Sexa significantly increased the risk of heart failure hospitalization. Vilda had no significant effect of LVEF but led to increase in LV volumes. So that means if you compare the patients had EF of 35%, it is much safer to use CETA and Lina rather than Vilda. Although Vilda can also be used because it does not increase the heart failure, but of course it had no effect. The ejection fraction did not increase but led to increase in LV volumes. That means heart was dilated further. So it's better to use linagliptin and sitagliptin. So patients of heart failure, linagliptin become the first choice. Robust real-world evidence with linagliptin complements RCT in clinical decision making. 2 US insurance database and South Korean database. Linagliptin associated with 26% risk of heart failure hospitalization. So not only it did not increase, but there are few data to suggest that has reduced the heart hospitalization because of heart failure. The two data, South Korean and 2 US insurance database, linagliptin associated with 23% lower risk of composite CV events versus second general sulfonylurea. So it is not only reducing the heart failure reduction, not only stable. That means this does not cause increase in the heart failure hospitalization, but on the other hand, this data has shown that it is reducing the hospitalization because of heart failure, and also it is also reducing the composite CV events. This was all about the advantage of linagliptins versus other gliptins in cardiovascular protection. Now we're coming to the renal evidence with linagliptin. So linagliptin has proven safety and effectiveness across the spectrum of chronic kidney disease, and HbA1c reduction with linagliptin across CKD spectrum preserved GFR over 1 year. So this is how it's a very nice slide which is made that with the patients who are on linagliptin, the eGFR is preserved over 1 year according to data which is published in this article. Coming to the Carmelina was specifically designed and statistically powered to evaluate both CV and kidney outcomes. And if you see the kidney outcomes with linagliptin, that means not only primary endpoint was 3P MACE and secondary endpoint was of course the kidney events, composite kidney events, and this showed that CV safety. This showed that it is safe as far as kidney endpoint is concerned, because it showed the sustained ESRD, sustained reduction in EGFR, and renal death. All these things were better with linagliptin in carbolina trial. The CV safety of DP4 in patients with kidney disease has been appropriately studied in carbolina trial, which has been published in various journals, especially this was published, and this has shown that baseline renal risk at DP4 CVOT, CV outcomes. The safety of linagliptin in patients with kidney disease has been appropriately studied only in carbolina trial, and there was 74% of trial population were having prevalent kidney disease. And this is demonstrated the long-term kidney safety with linagliptin, and this was pre-specified educated kidney composite outcome, ESKD, renal disease death of more than 40%, EGFR decrease, and of course, this is carbolina demonstrated overall long-term kidney safety with linagliptin. Learning from carbolina trial, risk reduction for albuminuria and linagliptin, 14% lower risk of progression of albuminuria and 15% greater likelihood of significant reduction of UACR. So overall, it is safe, and it also causing reduction in the progression of albuminuria, which is known in all kidney patients and diabetic patients. So not only we have been using lot of ACE inhibitors, ARBs, which are used for the patients of heart failure as well as for hypertension, and they have been shown to reduce the risk, reduce the progression of albuminuria. Now we have anti-diabetic drug, which is linagliptin, which is also causing reduction or lower risk of progression of albuminuria, and which is the first point in the progression of renal disease in all diabetic patients. The effect of linagliptin versus placebo on cardiovascular and kidney outcomes in nephrotic range proteinuria and type 2 diabetes, the carbolina randomized controlled trial, and they showed that it has got improvement in albuminuria and glycemic control and no effect on CV or kidney risk. Now coming to the third part, so we have discussed about the efficacy of linagliptin comparing with other gliptins. We have talked about CV safety, and we have also talked about the renal safety and renal outcomes. Now coming to the fourth point of all the gliptins, convenience and adherence. The DP4 inhibitors, clinically relevant pharmacological characteristics. This is highest binding affinity, highest reference. Terminal half-life is more than 100 hours. DP4 inhibitor at 24 hours post 80%, more than 80% control. Renal elimination only 5%. Dosage adjustment in renal impairment not required. Dosage adjustment in hepatic impairment not required. Coming to vildagliptin. If you see the vildagliptin, it has got a half-life of less than 3 hours, around 3 hours. Inhibition at 24 hours is only 40%, while with Lina is 80%. Dosage requirement is required in renal impairment, and dosage requirement in hepatic impairment not known, although potential for hepatotoxicity. So if you compare the most commonly used salt in India, teneligliptin, here although it is not required, dosage renal impairment is not required, and no impairment is severe impairment, potential for liver dysfunction. So tenagliptin, and if you compare vildagliptin, overall it is safe and there is no requirement of dosage in renal or hepatic dysfunction. Inappropriate renal dose adjustment of DP4 is associated with a poor clinical outcome diabetes. If you have a poor renal dose adjustment, then of course the outcome is also affected, and this is a very important study. And now since you don't require dosage, no patient on glitagliptin, if you don't require the renal dose adjustment, the overall outcome will be better. Dosage adjustment, renal impairment, linagliptin, find no dose adjustment. CETA, you have to teneligliptin 20 mg OD. If you have got a severe renal efficiency or ESRD, no dose requirement. While here in sitagliptin, you have to reduce the dosage from 100 to 25, saxagliptin to 5 to 2.5, vildagliptin, of course, from BD you have to make it OD, and then gliptin you don't require this. So if you compare all these three, there is no dose requirement. That's why it is bold and bigger size. It offers convenience of single dose, a simple method to maintain patients on licensed dosage without dose modification in CKD. What are the experience? Broad range of patients. Hepatic data, type 2 diabetes and diabetes mellitus. Liver disease consequence of diabetes mellitus due to glycemic deposition, NASH, fibrosis, cirrhosis, biliary disease, complete diabetic therapy. Diabetes occurring as a complication of hepatitis, cirrhosis, hepatocellular carcinoma, fulminant hepatic failure, post-cirrhotic liver transplantation, and 40-70% patients with type 2 mellitus will have a initial part disturbance in the liver functions. So safety, efficacy, and HbA1c index in hepatic impairment, DP4 in chronic liver disease, Lina is indicated, while Sita can also be used, Vilda not recommended, and Sexa and Tinu can also be used. Coming to the last part of, if you see, uh, Carmelina, no increased risk of cardio-renal old effects in older patients. Now coming to the elderly patients. So linagliptin has proven CV and renal safety across spectrum of CKD and type 2 mellitus. And Carmelina patient type 2 mellitus CKD are there. Dota. Or then the Carmelina no increased risk of cardio-renal events in older patients, and Carmelina no increased risk of CV, heart failure, or renal events in Asian type 2 mellitus. So Carmelina has been a very important trial to actually prove beyond doubt the efficacy, safety renal, safety cardio, adherence, and no change in dosage in renal as well as hepatic. So this is what has shown. So simplifying type 2 diabetes mellitus with linagliptin, proven effectiveness and the safety across broad range of patients in India, no need for dose adjustment, and stage of chronic renal or hepatic impairment, proven CV safety across broad range of cardiovascular renal risk, robust evidence of guidelines recommendation for effective and safe use of heart failure, long half-life and therefore can be used for once a daily dose, single dose, any age group, heart failure patients, any renal impairment, any hepatic impairment across all CVD risk and any race. So this is what is showing that linagliptin can be used in any age group, in all patients of heart failure, all patients of renal impairment, all patients of hepatic impairment across all CVD risk spectrum, including heart failure and any race and gender. So this shows that linagliptin is a better compound of all the gliptins as far as these five are concerned, and therefore it is better to stick to this single dose compound as compared to other gliptins. And of course, we are talking about only simplified diabetic mellitus therapy, and we don't want to use it. I hope the things are very clear. And am I audible and visible also? I'm stopped sharing the screen now.
Sir, you are not visible. You are audible only.
So when I will be visible?
So can you please open your camera so that we are able to see you? Now you are visible. Your
So in Engage, the problem that once you are having a slide share, your video becomes automatically off. But it does not happen with Zoom. Okay, doesn't matter. I hope the things have been clear. Are you able to hear me, Yusuf?
Yes, sir. Yes, sir. Yes, sir. Yes, sir. We are able to hear.
So we are not only, when you are speaking, we not only teach, we also learn a lot of things, and this is the advantage of webinars. And I hope the things have been very clear. So it is so many trials have shown. And of course, if we see that we are not only using linagliptin, we are also using vildagliptin, teneligliptin. And I remember 5 years back when teneligliptin, or 4 years back, was introduced. The basic reason why teneligliptin was introduced was the cost issue, and it was much cheaper. But there are some disadvantage in using, or rather, there are major advantage, I would say, in using linagliptin versus Vilda or teneligliptin. So we have to understand the efficacy point, renal safety, hepatic safety, cardiovascular safety, and of course the efficacy, and understand the adherence of dosage, because single daily dose, no change of dosage in any neither in ESRD, cross CKD, which is quite common in patient diabetes, any spectrum of heart failure, any spectrum of chronic or acute chronic coronary artery disease. So I think we are all convinced, and we hope that will be useful for the clinical practice of those who will be listening or watching it later on. And Yusuf has recorded. I think this can be put on any portal so that a lot of people can also watch later on. Especially you can put on the Facebook or you can put on the YouTube, so that this will be available for other people to see. Thank you very much. And anything else?
Sure, sir. Thank you for a wonderful presentation on linagliptin, sir. And at the same time, sir, I would like to request you. We have received some questions from our audience. If you allow me, I can read the questions.
Yeah, show me the questions.
Yes, sir. So first question we have received from Dr. Dinesh Chaudhary. He is asking, sir, how is your experience with linagliptin, and where do you rate this molecule amongst the DPP-4 inhibitor?
As we have told by Dinesh, Dr. Dinesh, nice question. As we have told that all the spectrum of slides, especially the trials of Carmelina, and we can use vildagliptin also, especially the patient is completely all right, a young man who does not have any chronic coronary artery disease, especially those patients who are complicated patients, especially with some early hepatic or renal involvement like albuminuria, or the patient who has got a low ejection fraction, or the patient who has had a history of CAD. It is better to use this compound, linagliptin, and a single dosage and a high efficacy also puts you on the pedestal that with even non-complicated patients of diabetes, uncomplicated diabetes, only diabetes, you can still use linagliptin. One should still use linagliptin, especially when you never know when you write a prescription. This patient may only 30% will come back to you, or 40%. The rest will continue taking these medicines over years together. And for example, a patient, a 45-year-old diabetic who has a languishing diabetes of 10 years, he goes away from your prescription and he continue to take any other gliptin, and he develops albuminuria, which is not confirmed, which is not recorded, or which is not actually diagnosed, and his creatinine start going up after 3 years, 4 years to 1.3, 1.4 because of some other reasons, hypertensive otherwise. And this patient will continue to take other gliptins. So it is better to start even in the non-complicated diabetes, these patients, this linagliptin. So I have very good experience myself, and I am using it thoroughly in most of my patients. Any other question?
Thank you so much. Next question we have received from Dr. Afaq Bansar. Dear sir, what is your personal opinion regarding linagliptin in terms of safety, like CV and hepatic and as well as renal? And what is your experience with efficacy?
No, no, it's okay. I'm very much I'm quite satisfied with both efficacy as well as safety wise, and I'm using it regularly. And I've never seen a patient deteriorating, especially the patient who has got a low ejection fraction, or who has got a any past history of hospitalization for heart failure, or the patient who has got a any history of low ejection fraction, or the patient who has got a high level of creatinine or 2.3 or 3 or 4. So we continue. Of course, we have to prevent taking these patients. If these patients are on metformin, we have to stop using metformin. And also, I am quite happy and satisfied because it does not cause hypoglycemia. And the patients who has got elderly patients, I am reasonably satisfied. I am using it very well, and hope that we can take the advantage of this particular wonderful salt in all the spectrum of diabetes, and many physicians should use it.
And sir, we have received next question from Dr. Usman Haja. And he's asking, sir, what is the Emperor Reduced trial and Emperor Preserved trial top line results? I heard about this. It is demonstrated significant reduction in empagliflozin for composite cardiovascular death or hospitalization.
Sorry. Can you repeat the question?
Yes, sir. Sir, he just wanted to know about the Emperor Reduced trial as well as Preserved Reduced trial. Of top line results, he heard about it is about this. It is demonstrated significant reduction with empagliflozin for composite cardiovascular death or hospitalization for heart failure in patient with heart failure with preserved ejection fraction. What is your opinion on it?
No, SGLT2 inhibitors, we have been using it, and the Emperor trial has shown a significant reduction. And in fact, whenever gliptins alone are not able to reduce the blood sugars, we have to add something. And especially since SGLT2 inhibitors have shown to be protective against reduction in heart failure, hospitalization, and also renal as well as cardiovascular. So we are using combination also. So I'm very reasonably satisfied with the combination of linagliptin with the SGLT2 inhibitors. So and there is no major disadvantage. And I'm happy that the company has also brought the combination. So you don't have a single tablet, and you have both the effects and utility of both the salt. And especially when the HbA1c is not getting controlled by single salt, which is gliptin, then you have to add this. And you have very rightly said that the Emperor trial has shown a very good results as far as SGLT2 inhibitor is concerned.
Thank you, sir. Thank you so much, sir. Yeah. Another questions.
I've got two
As the
patients waiting
linagliptin
actually.
yes, sir. As linagliptin has two dedicated outcomes trial. One is Carolina, other is Carolina trial. In both trials, outcomes have CV safety, renal safety, and reduction in the microalbuminuria. Do you have experienced these benefits in your patients?
Sorry, I could not. I was. Can you repeat the question? There are two trials, Carolina and Carolina
We
trial.
just
Both have
wanted
shown
to
the
know,
efficacy and safety wise. So, what is the question?
we just wanted to know your experience in terms of the benefits that have linagliptin as per two major outcomes trial.
Yeah, yeah.
That
So
is one
as I told you that we have been using this salt now almost for 2-3 years before the COVID, and overall we are fully satisfied. There is no deterioration, and in fact we have not done any study, but clinically when the patient comes back, he is happy and safe and smiling and with a good HbA1c reduction without any deterioration. So we conclude that the trials efficacy data as well as other data are completely correct, and therefore clinically we are yet to make any our own data are not there. I think we can start some data, especially the patients who are on both the combination as well as single dose.
And next question we have received. So, what is your opinion about linagliptin, especially in non-alcoholic fatty liver disease patients, which we have no 50% diabetic patients have this disease? How lina is effective as efficacy and safety in hepatic patients?
I have not completely watched this issue. I would be now happy to watch patients because we don't do normally if the ultrasound of liver is not done. And these patients are completely normal as far as the LFT is concerned. Liver function tests are normal. I think it's better to do start sort of it. That means whenever we start linagliptin or any other anti-diabetic therapy, we should have a baseline ultrasound which shows whether they have fatty liver or not. And if they have the fatty liver, whether there is progression by these medicines or not, I think we should now keep watching. As of now, we are not watching this because most of the patients will not have the ultrasound to have unless they have a comprehensive whole body checkup in Apollo. But we are not doing it regularly. But it's a good point that we should start watching this uh, uh, clinical item, which is very important because even non-alcoholic fatty liver disease can be dangerous and can lead to cirrhosis of the liver. And therefore, we'll start watching this now. And all diabetic will have one baseline ultrasound of the abdomen, which should rule out or confirm the presence of non-alcoholic fatty liver. And then we'll watch over a period of years. It's a good point.
Sir, thank you so much. We have not no more questions further. So, with regards to permission, I would like to sign off this meeting. Before going to sign off this meeting, I would like to say thanks to our audience who were connected with us for a longer time. And so, last question from BIN's point of view, sir. What is the take-home message you want to give
Take
to
home
our
message is that
audience?
gliptins are safe, and if you choose between the gliptins, the Lina is the most. Not only it's just safe, but it is also easy to adhere because it's always single dose and no dosage requirement, neither in CV or in stage liver disease. So you can easily say, okay, if you don't take medicines, even if you come back after 1 year or 2 years, you can continue to take this medicine. So it's very safe, and this is a very good message to all the physicians because I told you that only 40% will come back to you, only 30%. 70% will continue to take medicine for years and then come, unless they have problem, then only they will come back. So this our education, our society is not that educated, and therefore the take-home message is that all the gliptins, if you have to prescribe for the long term, Lila is the safest.
Thank you, sir. Thank you so much for your wonderful presentations. And sir, we would like to sign off this meeting with regards to permission, sir.
Thank you
We
so
will meet
much.
again, sir. Thank you, sir.
Thank you.
Have a nice day, sir.
Thank you.
Have a nice day, audience.
चल रही है
सो अभी जो बात हो रही थी वो एक्चुअली चर्चा चल रही थी एंगेज पे, नॉट ऑन जूम, रिगार्डिंग द डायबिटीज मेलाइटिस. डायबिटीज एक ऐसी खतरनाक बीमारी है जिसकी वजह से हार्ट प्रॉब्लम होती है, जिसकी वजह से स्ट्रोक होता है, जिसकी वजह से किडनी खराब हो जाती है, जिसकी वजह से आँख खराब हो जाती है, रेटिनोपैथी हो जाती है और लिवर भी खराब हो जाता है अगर अनकंट्रोल रखें. डायबिटीज की दवाएं कई तरीके की हैं. उसमें एक नई दवा है रिलेटिवली नई दवा है GP4 इनहिबिटर्स, जिसमें कि ग्लिप्टिन्स कहते हैं उनको। 4 तरह के ग्लिप्टिन, 5 तरह के आते हैं, सेक्साग्लिप्टिन, लीनाग्लिप्टिन, विल्डाग्लिप्टिन, टेनिग्लिप्टिन। तो डिस्कशन ये होता है कि 4 ग्लिप्टिन है। एक तो ओवरऑल सारे ग्लिप्टिन क्या बेटर है, सेफ है, तो इनमें सेफ्टी भी है, इनमें हाइपोग्लाइसीमिया नहीं होता। लेकिन कुछ दवाइयाँ जब ज़्यादा हो जाती हैं तो ब्लड शुगर कम हो जाता है। जब कम हो जाता है तो पेशेंट को पसीना आता है और कई बार बेहोश हो जाता है। वो रिस्क ग्लिप्टिन्स पे नहीं है, सबसे बड़ी बात यह है। दूसरा है कि अब 4 ग्लिप्टिन है, उसमें किसी पेशेंट को दिल का दौरा पड़ा, किसी पेशेंट को हार्ट अटैक हुआ तो हार्ट की पंपिंग कम हो गई, तो कुछ ग्लिप्टिन सेफ है, कुछ नहीं है, उनमें डोज कम करनी पड़ती है। किसी पेशेंट का किडनी खराब हो गई धीरे धीरे करके डायबिटीज वजह से, तो उसमें दवाइयों को डोजेज कम की जाती है। तो लीनाग्लिप्टिन एक ऐसा सॉल्ट है जिसमें ये सब चीजें नहीं है और ये सेफ है, एक सिंगल डोज है और काफी सेफ है। तो यही डिस्कशन था, इसका टेक होम मैसेज है डॉक्टर्स के लिए, फिजिशियंस के लिए, और जो लोग सुन रहे हैं फेसबुक पे उनको भी शायद अपने जो दवाइयाँ चल रही हैं तो बात कर लें अपने फिजिशियन से, क्या हम लीनाग्लिप्टिन ले सकते हैं, क्या चेंज कर सकते हैं। सो दिस इज जस्ट टू एजुकेट द पीपल, डॉक्टर्स एज वेल एज मास्टर्स। थैंक यू वेरी मच। प्रोफेसर डॉक्टर विवेक गुप्ता from Apollo Hospital, New Delhi, talking about diabetes mellitus in general. Thank you.
अभी हुआ नहीं मंथ।